Hello everyone, it's my pleasure and a great honor to share with you this very important lecture about tips and tricks in management of hypertensive patients with chronic kidney disease. Our agenda will include short introduction, definition and stages of chronic kidney disease, guidelines for management of hypertension in CKD patients, use of MRA in patients with chronic kidney disease, important tips about use of ACE inhibitors and ARBs in CKD, and finally diagnosis and management of hypertension in patients with chronic kidney disease maintained on dialysis. Let's start with a short introduction. Chronic kidney disease is an increasingly prevalent condition globally and strongly associated with incident cardiovascular disease. Hypertension is both a cause and effect of chronic kidney disease and affects the vast majority of CKD patients. Control of hypertension is important in those with chronic kidney disease as it leads to slowing of the disease progression as well as reduction of the cardiovascular risk. What about the definition and the stages of chronic kidney disease? Chronic kidney disease is subclassified into 5 stages, starting with the stage 1, which is defined as GFR 90 or more, plus evidence of structural or functional renal abnormalities. Stage 2, GFR between 60 and 89, plus structural or functional renal abnormalities. Stage 3, GFR between 45 and 59 is called Stage 3A. GFR between 30 and 44 is called Stage 3B. Stage 4, GFR between 15 and 29. And finally, Stage 5, GFR below 15 or dialysis. According to the American College of Cardiology guidelines for management of hypertension, chronic kidney disease is defined as stage 3 or higher, or stage 1 or 2 with evidence of albuminuria 300 mg per day or more, or 300 mg per gram albumin to creatinine ratio in the first morning void. While the European Society of Cardiology for Management of Hypertension defines CKD as GFR below 60 with or without proteinuria. What about the management for hypertension in CKD patients according to the guidelines? This table summarizes the recommendations and the difference between the European and the American guidelines for management of hypertension. As regards the blood pressure goal in the American guidelines, it is less than 130 over 80 mm mercury. In the European guidelines, the blood pressure goal, systolic blood pressure between 130 to 139 and the diastolic blood pressure between 70 and 79. In presence of proteinuria, the American guidelines recommend ACE inhibitor as a class 2A and ARBs as a class 2B, while the European guidelines recommending RAAS blocker, either ECI or ARBs, in presence of proteinuria, and both were given class 1 recommendation. In absence of proteinuria, the American guidelines recommend the usual first-line medication choices such as ACE inhibitor, ARBs, calcium channel blocker, and diuretics, while the European guidelines recommend the combination of a RAAS blocker with calcium channel blocker or diuretic is recommended as initial. What about the use of MRA in patients with chronic kidney disease? Mineralocorticoid receptor antagonists such as spironolactone is very effective medication for management of refractory hypertension by anti-aldosterone action. However, side effects, especially hyperkalemia and the decline in the kidney function, are a concern when added to a background therapy with ACE inhibitor, ARBs, or diuretic, particularly among patients with GFR below 45. Thus, MRAs shouldn't be used in patients with high risk of hyperkalemia, such as patients with hypoaldosteronism or type 4 renal tubular acidosis. You can also consider the dose adjustment of spironolactone in CKD patients. If the creatinine clearance above 50, you can give 25 mg spironolactone once daily. If the creatinine clearance between 30 and 50, consider initiating the spironolactone at 25 mg every other day with close monitoring of the serum potassium. And in general, patients who develop hyperkalemia on 25 mg once daily, you may consider reducing the dose to 25 mg every other day. What about the use of ACE inhibitors and ARBs in CKD? Before prescribing RAS blocker in patients with chronic kidney disease, you have to balance the risk versus the benefit. The risk or the barriers to continuation or initiation of RAS blockers in CKD patients include hyperkalemia, acute kidney injury, uncertainty or fear by the physician, or rapid decline in the kidney function. However, the benefits of initiation or continuation of RAS blocker include delay in the CKD progression, decrease in the major adverse cardiac events, and reduction in the mortality. In patients with chronic kidney disease who receive blood pressure lowering therapy, especially in those treated with ACE inhibitors or ARBs, blood pressure lowering reduces the renal perfusion pressure, and it is expected and not unusual for the GFR to be reduced by 10 to 20% with rise in the serum creatinine less than 30% from the baseline. An increase in the serum creatinine level, if it occurs, will typically happen during the first 2 weeks of treatment initiation, and it should stabilize within 2 to 4 weeks in the setting of normal sodium and fluid intake. A change in blood pressure, serum creatinine, serum potassium should be checked within 2 to 4 weeks of initiation, or increase in the dose of the RAS inhibitors depending on the baseline blood pressure, current GFR, and serum potassium. However, in patients at risk for hyperkalemia, such as high baseline serum creatinine, serum potassium level is already high normal, or there is a history of hyperkalemia or acute rise in the serum creatinine with blood pressure lowering, it is recommended to measure the serum potassium level before and 1 to 2 weeks after initiation of the RAS inhibitor. Rise in the serum creatinine more than 30% or reduction of the GFR by more than 30% from the baseline, the treatment should be stopped and you have to rule out renovascular disease or renal artery stenosis and check for volume depletion and rule out the use of nephrotoxic drugs. In most patients, the ACE inhibitor or ARB can be continued if a GFR decline over the 4 months is less than 30% from the baseline value and serum potassium not exceeding 5.5 milliequivalent. Consider reducing the dose or discontinuation of ACE inhibitor or ARB in the setting of either symptomatic hypotension or uncontrolled hyperkalemia despite the medical treatment. On the other hand, withholding these drugs only on the basis of the level of kidney function will unnecessarily deprive many patients of the cardiovascular benefit and perhaps even protection of the residual kidney function that they otherwise would have received, particularly when measures could be undertaken to mitigate the risk of hyper. And you should put in your mind that the causes of early decline in the GFR include volume depletion, hypotension, renal artery stenosis, either bilateral or unilateral in presence of solitary. Conditions in which ACE inhibitors or ARBs shouldn't be used include pregnancy, history of cough or angioneuritic edema or other allergic reaction, bilateral renal artery stenosis, serum potassium level more than 5.5 milliequivalent despite treatment, GFR decline more than 30% within 4 months without explanation. How to use ACE inhibitors or ARBs safely in patients with chronic kidney disease. Obtain a baseline blood pressure and serum creatinine level, GFR and serum potassium before initiation of ACE inhibitors or ARBs. Start at a low dose with gradual dose up titration after at least 2 weeks interval until you achieve the target dose. Follow up serum creatinine, GFR, serum potassium after 2 weeks or only after 1 week if there is an increased risk of hyperkalemia. Avoid nephrotoxic drugs such as non-steroidal anti-inflammatory drugs. Avoid hypovolemia and hypotension and consider potassium binders such as patiromer. You also can consider the dose adjustment of the RAAS blocker in CKD patients, for example, ramipril in patients with creatinine clearance below 40 with concomitant diuretic therapy. It is recommended to give 25% of the normal dose, starting with 1.25 milligram daily, and the maximum dose will be 5 milligram daily. What about valsartan? Valsartan in patients with creatinine clearance 30 millimeter or more, no dose adjustment is necessary, while the creatinine clearance below 30, also no dose adjustment provided in the manufacturer labeling, but use it with caution. In dialysis patients, the drug is not significantly removed through dialysis. You can start with 80 milligram daily and the target dose is 160 milligram. What about the use of ACE inhibitors and ARBs in advanced CKD patients? Advanced CKD is defined as CKD stage 4 or CKD stage 5. We have two questions here. The first one is there a benefit from the use of ACE inhibitors and ARBs in advanced CKD? The antiproteinuric effect of RAAS inhibitors is thought to contribute to slowing the progression of CKD. However, the benefits of using RAAS inhibitors in advanced CKD stage 4 or stage 5 are less certain and still under debate. In fact, meta-analysis investigating the combined association of GFR and albuminuria with mortality in general population showed that the advantage of less urinary albumin excretion for lower cardiovascular mortality risk disappeared in patients with GFR below 30. So, in conclusion, we don't have evidence about the benefits of use of ACE inhibitors and ARBs in advanced CKD. Still, it's a matter of debate. The second question is there a harm from use of ACE inhibitors and ARBs in advanced CKD? This was addressed in the Stop ACE trial that was published in the New England Journal of Medicine in December 2022. The study question in this trial was: does the discontinuation of RAAS inhibitors improve GFR in patients with advanced CKD? This multi-center UK-based trial randomized about 400 adults. About 200 used the RAAS inhibitors and another 200 discontinued the RAAS inhibitors. All participants had CKD stage 4 or stage 5 CKD and were not on dialysis and had not undergone kidney transplantation and had experienced a GFR drop more than 2 mm per minute per year in the last 2 years prior to the study. Treatment with an ACE inhibitor or ARB or both for more than 6 months prior to the study was also an eligibility requirement. About 85% of the participants were white and the median age was 63 and about 68% were men. The most common sources of CKD were GN, glomerulonephritis, hereditary disease including autosomal dominant polycystic kidney disease, renovascular disease or hypertension, and diabetic nephropathy or other causes and other unknown causes. The results of this very important trial and the conclusion was they found no significant differences in GFR after quitting or continuing the RAAS inhibitor in patients with advanced CKD. They also found there wasn't a significant difference between the two treatment pathways when it came to progression to end-stage kidney disease or initiation of renal replacement therapy or more than 50% decline in the GFR. Also, there is no significant difference in the cardiovascular or vascular or heart failure events between the both group and also no significant difference in mortality or all-cause hospitalizations. Our findings don't support the hypothesis that discontinuation of RAAS inhibitors in patients with advanced CKD would improve the kidney function, quality of life, or exercise capacity, Bindari group concluded. While the use of RAAS inhibitors like ACE inhibitors or ARBs is a standard practice in patients with mild or moderate CKD in order to lower the blood pressure, to slow the GFR decline, to reduce the proteinuria, Bindari group said there was little prior evidence backing their benefit in advanced CKD. The last part of our lecture is about the diagnosis and the management of hypertension in patients with chronic kidney disease who are maintained. Diagnosis of hypertension in dialysis patients is done by home blood pressure monitoring. Average blood pressure more than or equal to 135 over 85 millimeter mercury for measurements collected in the morning and in the evening over 6 non-dialysis days, covering a period of 2 weeks. So you want at least 2 weeks of measurements, and you will measure the blood pressure in non-dialysis days twice per day, once at morning and another time in the evening, taking the average of the blood pressure over these 6 days in home, and if the blood pressure value is equal to or more than 135 over 85, then you can diagnose hypertension in dialysis patients. Measures should be performed in a quiet room with patient in seated position with back and arm supported, and after 5 minutes of rest, with 2 measurements per occasion taken 1 to 2 minutes apart. How to manage hypertension in dialysis patients? First to do by the nephrologist is to avoid positive sodium balance induced by the hypertonic dialysate and or sodium profiling during the volume status adjustment. And it is also recommended to reduce the dialysate temperature when intradialytic hypotension limits the ultrafiltration. If antihypertensive agents are required, select agents with pharmacokinetics suitable for dialysis patients and appropriate for existing comorbid conditions, and consider longer hemodialysis session duration. This will help in control of blood pressure. What about the pharmacotherapy of hypertension in dialysis patients? Evidence to support the preferential administration of one antihypertensive drug class over another for pharmacological management of hypertension in dialysis is currently missing. The choice of the appropriate antihypertensive regimen should be individualized and based on the blood pressure lowering efficacy of the drugs, blood pressure independent cardioprotective properties, intradialytic and interdialytic pharmacokinetics, whether the drug is dialysable or non-dialysable, and finally the tolerability and the side effect profile as well as the comorbidities of each patient. Post-dialysis dosing or extra doses after hemodialysis may be necessary for certain antihypertensive agents. For example, ACE inhibitors all are dialysable except fosinopril. ARBs are non-dialysable. Beta blockers, atenolol and metoprolol are dialysable, while nebivolol and carvedilol are not dialysable. Calcium channel blocker amlodipine is not dialysable. So what is the first line management of hypertension in dialysis patient? It is beta blocker, especially carvedilol and nebivolol. The second line is dihydropyridine calcium channel blocker such as amlodipine and nifedipine. The third line is ACE inhibitors or ARBs such as fosinopril and valsartan. And the last line is the other drug classes such as centrally acting agonist, direct vasodilators, alpha blocker. All these drugs are frequently associated with serious side effects and their use should be limited to patients with difficult to control hypertension. So my final take home messages: managing hypertension, especially when accompanied by chronic kidney disease, is challenging. Hypertension is the second leading cause of CKD, second only to diabetes. Although optimal blood pressure control is important for all patients with hypertension, in patients who have comorbid CKD, blood pressure control is crucial to slow the progression of chronic kidney disease. The early recognition of both kidney disease and hypertension may ultimately help to reduce the risk of cardiovascular events and advanced kidney disease, including end-stage renal disease necessitating renal replacement therapy, either dialysis or renal transplantation. The disadvantages and the benefits of RAAS inhibitors initiation or withdrawal in patients with advanced CKD have yet to be clearly answered in a large randomized controlled trials. These are our references, and thank you so much.